of the panel who are participating remotely today. That would be Dr. Berger. Dr. Berger, are you with us?
I am with you.
Look at that. It works. It
That
works.
was Berger from the heavens.
How about that? Yes, your voice comes from on high, comes to us from on high. And Judge Grimm.
Good morning.
Good morning. Well, my goodness, all this works. For the record, we certainly have a quorum. Then we have present in person, Mr. Ipock, pardon me, Ms. Bernard, Mr. Koudalakis, Dr. Christian, myself, and your last name? Makareth. Ms. Makareth from the Department of Welfare. All right. We are ready to proceed. Our first speaker for the morning is Dr. Turkowitz. Doctor, you with us? If you'll step up and have a seat and press the button on the microphone before you so that we can record your words. Thank you for joining us this morning. And for the record, Dr. Turkowitz is the chair of pediatrics at York Hospital and the immediate past president of the Pennsylvania chapter of the American Academy of Pediatrics.
Thank you. Good morning. I will begin my testimony with acknowledgments to the following people. Kathy Palm for her leadership of the Protect Our Children Committee and advancement of the idea of a Pennsylvania Child Abuse Task Force. The legislature and governor for bringing this task force to fruition, and the 11 members that were chosen and agreed to serve. The challenges that you face are really tremendous. And looking at the time frame, if I have it correctly, it's November 30th to have a final report. And I think that's probably going to seem like an exceedingly short time, but looking at the individuals on the task force, I think you're going to be up to it. Wouldn't it be nice if there was a state model out there that was holistic, fiscally responsible, evidence-based, outcomes-driven, logistically feasible, broadly acceptable to all, and replicable? Unfortunately, that model doesn't exist. This task force was conceived out of tragedy, a public outcry that is again flaring with the news accounts of the Sandusky trial. While there is not one system out there that we can lift in entirety, there are best practices that we can and should incorporate into our approaches to child abuse prevention, recognition, provision of services, and prosecution of those who victimize our children. I'll expand a little bit on my background. This task force has heard from many individuals. I'm not sure if all the opinions if there's been a lot of overlap or diversity. So to a degree, I know some of the task force members, but most I don't know. And I'm going to tell you a few things about myself that hopefully will mean that you'll listen to me, and maybe that this will help shape your final report. I'm a pediatrician with expertise in child abuse. I've examined over 1,000 suspected child abuse victims. I practice at community hospital settings. I'm currently chair of pediatrics at York Hospital. I began my career at the Children's Hospital of Philadelphia, and one of my mentors is Dr. Steve Ludwig, and one of my colleagues I worked with there, Dr. Cindy Christian. As I mentioned, I'm chair of pediatrics, professor of pediatrics at Penn State. I have lots of involvement in the area of sexual abuse. I'm the physician, pediatrician advisor to the Sexual Abuse Forensic Nurse Program, which has created a really tremendous program for children at York Hospital. I'm the medical director of two independent children's advocacy centers, the one in York County and the one in Adams County. I've served on the Pennsylvania Medical Legal Advisory Board for about 24 years or so, past president of the American Academy of Pediatrics, and one of the activities of the chapter, the Pennsylvania chapter of the American Academy of Pediatrics, has been the Child Abuse Task Force. Under Cindy's years of direction, the task force had just a tremendous track record of accomplishments. Some of the things that I'll touch on this morning, the Mark Diaz Shaken Baby or Abusive Head Trauma Prevention Program. The inception of that was through this child abuse work group and the Pennsylvania Commission on Crime and Delinquency. I remember when we brought Dr. David Olds to meet with us, and we looked at his literature, and those meetings were the seed for the development and now our experience in Pennsylvania with the Nurse Family Partnership that I'll talk a little bit more about. The Pennsylvania chapter and many of the folks that are on that work group have also been involved in EPIC Scan, educating physicians in community and the areas of child abuse, and I'll touch on that too. Also, I have no personal agendas for being here. I just want to see our children have better systems than we currently have in place. I'm going to move on and just cover some really basic facts. And I wasn't sure if I should include this given my limited amount of time, but I kind of just thought about some of the talks that I heard Dr. Ludwig give, one of my mentors. And I think sometimes we make things too complicated, and we just got to focus on, what are the root facts? And if we can't agree with them on them, I think then we're going to have some difficulty moving forward. Some of these facts are embedded in strong evidence, literature evidence. Others are the consensus of experts. First, child abuse is ubiquitous. If child abuse was an infectious disease, we would consider it an epidemic. When you look at the really broad-based acceptance of literature for sexual abuse, and that 1 in 4 to 1 in 7 women, 1 in 5 to 1 in 10 men, and you might quibble a little bit with the statistics, but it's there. That's truly epidemic. The numbers are real. They can't be trivialized. There's some discussion that I periodically see in editorials that these are statistical artifacts of how we investigate things. It can't be ignored. The numbers are real. There are a myriad of presentations of child abuse. On one end of the spectrum are cases of savagely beaten children with bruising, broken bones, internal hemorrhage, and organ damage that can only be caused by abuse. These are cases that any layperson or physician would recognize. Then there are infants and children who present with features that may outwardly suggest abuse, but a vigilant medical search by specialists with training in child abuse uncovers an underlying medical etiology rather than abuse. Sexual abuse cases can be the most difficult. More than 90% of these children have normal exams. In these cases, prosecution for the victims and justice and services for the child can only be obtained through meticulous and coordinated work of professionals across multiple disciplines. I put this here because this is difficult work. It can't be done by one discipline. We have to listen to each other, and we have to learn how to cooperate across some of the boundaries that exist. Child abuse has consequences for the victim. Some may be short-lived because of the nature of the abusive act or acts, the child's resiliency, and a variety of external factors. We know from the Adverse Childhood Experiences studies, and these are longitudinal studies that look at events such as child abuse, family dysfunction that occur in childhood, do have persistent markers in adulthood in terms of increased frequency of behavioral health problems and increasing array of many of the chronic diseases of adulthood. Then there are some child abuse fatalities. For these children, there is no need to think about probabilities, but rather all the implications of a life lost. I'm going to give you 2 brief stories. Derisabel Baez died one day after her 2nd birthday. I first saw Derisabel when she was transported to York Hospital, already on life support. The EMS responders found her at home without a heartbeat or efforts to breathe. They were told that she had fallen down the stairs and was put in the bathtub to help revive her. Derisabel had numerous rectangular areas where her skin was severely abraded, and in the back of my testimony, I photocopied one of the line diagrams that was published in the York paper. Most of the rectangular areas had an attached curved line. I wondered what could have caused these markings. Further investigation uncovered that during Derisabel's fatal beating, she was struck multiple times with a video controller game. A week or so ago, so this was just last week, I was asked to see a young girl with physical exam findings and a history suggestive of sexual abuse. As I talked to the mother about what comes next, something that I always do in terms of what we're going to do medically, what children and youth is, what to expect from children and youth, what to expect from police. Mother shook her head and said, yeah, I understand. So I asked her the next obvious question, saying, well, how come? How do you know this? She then went on to tell me about her sexual abuse by her stepfather, which occurred between the ages of 5 to 14 years old. The abuse stopped when she was able to tell a school teacher. That stepfather is now elsewhere in the United States. I asked her how she was doing. She told me that she will never feel normal again. I did not ask her how she felt about the possibility of her little girl being a sexual abuse victim, because you can only imagine those hellish thoughts. Next point, early recognition and appropriate intervention can and does reduce the likelihood of further abuse that may be fatal. I think we really have to buy into this. It's true. So many things in the medical literature point out that when physicians miss cases of abusive head trauma, thinking that it could be anything else, that there's a significant likelihood, 10, 20, 25% of those children present re-injured, a few children present fatally injured. Personal suffering and death aside, the cost of child abuse is staggering. In preparation for my testimony today, I looked at several of the kind of the life table type statistics, and again, I think you can get a room full of people that are arguing whether it's 100 million or 10 billion or not. The bottom line is I don't think that there's any argument that the cost of missed cases of abuse and that abuse occurs are just enormous and needs to be strongly considered with the upfront dollars needed to support children and youth services and prevention programs. The root causes of abuse are not obscure and differ depending on the type of abuse. The root causes of abuse must be considered in developing any prevention strategy. I'm now going to move on to, I guess, my suggestions. Kind of presumptuous, but that's why you asked me to come. So I'm going to give you some suggestions for this task force to consider. I apologize if some of my comments and suggestions are repetitive. I did have the opportunity to look at two of the testimonies, and that's it. Every local children and youth agency should have healthcare professionals with expertise in child abuse serving as closely integrated consultants. Has to be. This is too multidisciplinary. I've worked with children and youth people for more than 30 years. I don't know the business of children and youth. They've worked with me for many years. They don't know my business. Good outcomes can't be achieved unless we work together. Every case, whether it's neglect, whether it's abuse, we're often leaving caseworkers and supervisors in pivotal decision-making responsibilities. And it's just the very egregious stuff that comes to me. That's wrong if we're just dealing with the tip of the iceberg. Multidisciplinary evaluations involving children and youth are already mandated by the recently legislated fatality and near fatality review. Isn't that wonderful? We have a template to bring this and to expand this activity to the core of children and youth services. Pennsylvania also has a long history of multidisciplinary review in the area of child death that is now codified by legislation. Again, many of the same individuals that sit on all these local child death review teams are also involved with children and youth services. So the model is out there. One of the greatest benefits that we've achieved through child death review is the development of positive working relationships and better decision-making than was possible when individuals in different fields, law enforcement, children and youth, medical fields, behavioral health, worked separately. Also, another benefit is the collegial relationships that are developed when everybody is sitting at the table. You learn to address the person. You're not just speaking to them over the phone, and better things happen in terms of cooperation. While it is true, I guess one of the comments is that where are all these child abuse specialists going to come from? Pediatricians are trained in the field of child abuse. So one does not have to be fellowship trained to be an expert in child abuse. I think eventually, over the next 10 years or so, the curve is going to be changed, and I think child abuse fellowship is probably going to largely define expertise. But it's not true now. We've recognized this issue in Pennsylvania, and in 2003, the Pennsylvania chapter of the American Academy of Pediatrics developed a preceptorship in child abuse. And two members of the task force here, Dr. Cindy Christian in Philadelphia, Dr. Rachel Berger in Pittsburgh, have led this efforts, and to date we've trained 29 pediatricians across the Commonwealth to, again, make sure that physicians with an expertise in child abuse are available. By the way, I didn't time how long I was talking, so give me a beep if I have 2 or 3 minutes to go.
We started a bit late, Doctor.
Okay. All right. Okay, then we, yeah. Let's call for lunch. Okay, just kidding. Okay, second point. Pennsylvania's child abuse legislation obviously requires revision. Doesn't mean that the whole thing has to be thrown out, but it needs to be revised. The legal definition of child physical abuse in Pennsylvania hinges on a guesstimate of what causes severe pain and what defines disability. It's just far too nebulous. And I've seen and I've read other systems, and yes, I know that there's nothing perfect, but it's just too variable. So the response shouldn't be, well, it's a stoic child, and that bruising didn't cause severe pain. And even just the concept of what causes temporary disability, if a child is paddled and is limping for the next half hour, is that a temporary disability? We can do better than that. And I would suggest that the task force look at the many states that really provide explicit, concrete thing. This is abuse. Again, it's not going to define every situation, but I think it will. I think that's important to reducing variability. The child abuse neglect definition is so severe that Pennsylvania's child abuse data cannot be meaningfully aggregated with data across the country. And yes, I obviously understand that Pennsylvania has a two-tiered system in terms of CPS investigations and general protective services and valuation, and that we're not ignoring the cases that don't reach the abuse threshold of neglect, that they're at a GPS level, but it's another world. Yes, it's managed within CYS, but it's managed without directives in terms of outcome measures or prioritization. And I think we should just get with it. Again, this is not my interest to label, to increase our abuse numbers. It's my interest that children get services that they need. And by having this two-tiered system with lesser support services for neglected children, and again, there are so many examples. The diabetics, asthmatics. I just had one in the hospital a week or 2 weeks ago. Just isn't getting his controller medications. Hospitalized 3 times in the last 3 months. Pretty sick, needing ICU care. Does that meet our neglect provision? Sometimes it depends. Some people look at it and say yes. Some people say no. But I think one could clearly argue that that's life-threatening. Reporting of school-related abuse is confusing. I've been doing this a long time, and I'm still confused. And reading all the newspapers about the Sandusky stuff, I'm not alone. Everybody is confused in terms of all the grayness there. Throw that stuff out. It makes no sense. It is not child-focused. It's built because of, I think, of just more from the service providers, whether there was something about schools or whatever that they felt that needed to be placed, but it's not child-focused, and it makes our system so difficult to comprehend. And it's one of the factors that led to the Sandusky tragedies. You've got to make that better. I am comfortable with the term reasonable suspicion. I'm mentioning that because I don't know if this came up with the task force, and there's been some literature out there that we have to clean up this term or add some extra weight to what does it mean, the reporting threshold of reasonable suspicion. No degree of wordsmithing. What's a reasonable suspicion to one mandated reporter is going to be different. For instance, a child that comes to the ER with a femoral fracture. This happens several times. Little people in general don't fracture the big bone in their leg. But sometimes they do because of accidental reasons. We train doctors to strongly think about the possibility of abuse. So when my ER doctor says, gee, that's possibly abuse, and files a report, that is a good thing. I've had cases where I've come in the next day and I've taken a history and gone through things and said, gee, it didn't reach my threshold. The history was very precise. The pattern of the fracture makes sense to me. The ER was not wrong. They were acting within their scope of knowledge, and it's that scope of knowledge and experience that defines reasonable suspicion. And I urge this task force not to perseverate on this issue too long because I don't think wordsmithing improves it. Next point, and I could have elaborated, but I'm pretty succinct here. Pennsylvania must have an independent group to prospectively monitor the functioning of our child abuse system and serve in an advisory capacity. Too important, too big, too multidisciplinary in nature. So expensive for the Commonwealth. And when you think of the total cost of services and looking at outcomes, the cost of creating an oversight to that activity is minuscule, rather than, accepting the status quo. If things were working in the past or looked like they were working, I would say, well, go for it. But then it's not working, and we can do better. And I think this independent person, group, task force, whatever you want to call it, should be in place. Next, evidence-based, fiscally responsible prevention programs should be accessible throughout Pennsylvania. The Nurse-Family Partnership that I mentioned earlier is extraordinary and almost unparalleled in terms of the fidelity of the data that supports the outcomes that are achieved when this service is provided to disadvantaged moms. And I'm so happy that this program has been, that has received ongoing support, from the governor and the legislature. It needs to be expanded. So we're doing good, we need to do better. There are so many other prevention programs, maybe not at the same fidelity level as the Nurse-Family Partnership, but do have promising data. This is not all-inclusive, and I'm not the expert on prevention. I'm more a doc who works in hospitals. Other people can talk more about prevention than I can. Healthy Families America, Parents as Teachers, Darkness to Light, a child sexual abuse prevention program, One Kind Word from Pittsburgh, and the Front Porch Program. I'm going to spend a minute or two talking about the Front Porch Program. Next week, through grant support from the Pennsylvania Department of Health, there will be a Front Porch training program in York. This is particularly fitting because it was the Darissa Baez tragedy that led Angela Little, who is at the Pennsylvania Family Support Alliance, to think, what can we do in Pennsylvania to turn this around? She then looked at programs out there, found this Front Porch program through the American Humane Association, partnered with the American Humane Association, and has brought this program back to back to Pennsylvania. And now it's very fitting that we're trying to expand this program in York. What I'm trying to achieve through the grant is what I call a tipping point. I think if the program just reaches 10, 15, 20 key individuals, what's going to happen? Probably nothing. But what's the kindling if we can train 100, we can train 200 individuals that have key positions within the community? Pennsylvania must move from a mindset that child abuse can be eliminated through the efforts of more vigilant local children and youth services and law enforcement. Programs like the Front Porch Program promote the concept of neighborhoods serving as safety nets for children. In York, we're taking it one step further. We're coupling this Front Porch Program that works on what to do and recognition to also looking at the area of parenting. And to a degree, the Darissa Baez tragedy was a fatality that started as out-of-control discipline. So what we're going to try to do is reduce parental reliance on corporal punishment and talk about other strategies. When you look at the literature on corporal punishment, it's really quite straightforward. There's only one positive outcome of corporal punishment, is that you will modify short-term behavior. Everything else after that is negative. I guess another way to think about corporal punishment is beating a child to achieve the right behaviors. Now, if we start calling it beating a child to achieve the right behaviors, doesn't make any sense. Who could argue for that as a strategy? And so I think that should really be fundamental in terms of coupling children and youth. It doesn't have to be that prevention programs have to be within children and youth, but they have to be seamless and accessible. Next, training for healthcare providers on recognition and management of abuse must not just be sustained, but also expanded. In 1998, the Pennsylvania chapter of the AAP launched the Educating Physicians in Community Suspected Child Abuse and Neglect Program, otherwise known by the acronym EPIC-SCAN. Since the inception of this program, Pennsylvania has developed multiple variations of this program to reach other healthcare providers, including not just office people working in the community, but hospital staff, school nurses, and EMS personnel. Pretty amazing. 1,012 EPIC programs have been locally delivered as of this last month, reaching 21,751 participants. Sorry to throw in a statistic, but figured I'd have one. A unique feature of the EPIC program is the co-delivery by a physician and a local children and youth representative. That's really key to this program. The shared presentation models the collaborative relationships between children and youth and healthcare that must exist. Also, the participants now have a face-to-face contact with one of the children and youth workers, typically a supervisor in the community. It makes all the difference when the office says, okay, I know that person to call, not just a number in the phone book. It's really a game changer. The Pennsylvania AAP has already piloted a modified EPIC scan program for early intervention providers, and the attendee responses were positive. Early intervention professionals include speech, occupational, and physical therapists. These workers provide services to children under 3 years of age with developmental disabilities that are typically provided in the home, which is the least restrictive environment. Children with disabilities, as much as we hate to think this, are children that are an at-risk group for abuse. This is a tremendous opportunity to train these workers who are going into the home, providing services in terms of recognition, reporting, and assisting with parenting. Additional funding is required to sustain and expand the EPIC scan presentations to include early intervention workers, and we could go further than that. Next, training of mandated reporters must be supported. Survey data in 2010 involving 1,200 Pennsylvania mandated reporters revealed that close to 40% lacked either any training or didn't have an update since 2007 when the law was substantially changed. My experience with teaching healthcare professionals, and aside from being an EPIC scan lecturer, I do this every month, talk to physician groups, is I wouldn't say they're clueless, but they're closer to clueless than well-informed in terms of the specifics of the law. Got to change. They're mandated reporters. Childline. People don't know about Childline. Even mandated reporters don't know much about Childline. It needs to be more public, whether it's billboards, whether it's something. It needs to be part of public awareness. Next, Childline operations need to be rectified. While this is somewhat old data, in 2010, one finding was approximately 9% of the calls to Childline were abandoned or deflected. I recently had the same experience, and by recently, this was about 4 or 5 months ago. I was referred a child from a family physician who had some concerns. I thought the concerns did reach my threshold for reporting. I tried 3 times to call the Childline number. Each time sat on the rotary phone, ended up in a different direction, and the call was dropped. You guys are busy. I'm busy. I'm sitting there. I don't have a secretary doing this or a receptionist. After that cumulative 9 or 10 minutes, I gave up. Now, unlike most, I didn't just give up and walk away. I called my York County Children and Youth, spoke to one of the supervisors, and reported it through that back door. But think about what's probably the more typical situation is that it takes a lot of courage to call Childline. That when you think of what may happen and you remember what I said about missed cases of abuse, one drop call could be one fatality. Communication between children, next point. Communication between children and youth and the reporting healthcare provider must move from a minimalist information back to the provider to a more detailed response. The reporting healthcare provider may be the child's pediatrician, maybe the child's family physician, and who's providing a medical home, who needs to know enough things about the child to really provide care. I really think about what children and youth do as they're a consultant, they're a specialist, they're working within the community in behavioral health and family function. And as an analogy, think if I had a child that I suspected congenital heart disease, and I referred him to the cardiologist, and the cardiologist does an echo, and I get a report back saying, you're right, the child has congenital heart disease. Boom, signed. You know, what do I do with that? I want to know what the child has, what services are going to be providing, so I can help you. I know what to look for when the child comes to my office. And if you want the buy-in of physicians, don't leave them out there. This is just too frustrating. My final point, all children and youth agencies should have established relationships with regional children's advocacy centers. There are over 20 children's advocacy centers in Pennsylvania, many of which have received national accreditation. While there are idiosyncratic differences between these centers, each of the centers to achieve accreditation must have the same basic tenets. These are facilities that are child-friendly, developmentally appropriate. They're kind of a hub-of-a-wheel model. The child comes in, they're interviewed by a trained forensic interviewer that may have a background in psychology, behavioral health, nursing. It avoids the trauma of repetitive interviews. And it's not just the trauma. When you take a little person and you keep asking them the same question, a little person can only think, what have I said wrong? You know, why are they doing this again and again? And the story gets distorted. In Pennsylvania, then it starts magnifying the possibility of taint. So the child has said something in the wrong way and everything gets thrown out. Remember, 90% of children who are sexually abused have no physical findings. And if we're going to achieve safety for that child and justice, we have to obtain histories in the best way. Children's Advocacy Center, we don't have to remake the model. We're replicating it. It works. It needs to be supported. It is financially challenging. But I think if you look at the 20-plus centers in Pennsylvania, they tend to they're preserved because I think once they've formed in the community, the communities find ways to support Children's Advocacy Center. Although it would be nice to have a more secure funding stream. Well, I apologize if I was a little bit random or rambling. Thank you for this time this morning, and I welcome any questions. And also, since I don't have all the answers, there's members of our Pennsylvania Child Abuse Work Group, Alan Young, and work group members. So if I can't answer something, I'm going to defer it to members of the audience here.
Well, thank you very much, Doctor. Let me set the record right. Ms. Rumberg, you usually sit on the other side, and I missed you. But Delilah Rumberg is also with us. And would you like to start the question?
Yes. Thank you, Dr. Turkowitz. And being a local York County community member, I know you've done some work with I don't even know what the group is as a result of Darissa Bell's death. I know you started working with Aaron Anderson and some local community leaders. And could you talk a little bit about that and also what you think maybe the next steps would be? And are there ways to replicate that kind of community bonding, I guess, around the issue of child abuse in a community?
Well, that's such a great question, and it's almost like I planted the dolly. So really, thank you so much for asking. After Darissa Bell's death, about a year later, there was a community forum held at the Jewish Community Center in York. I would say a rough count, 800 to 1,000 people may have attended, a room filled with people. And it was basically a late afternoon, early evening program of angst. How could this happen? You look at the pictures of Darissa Bell, and she's beautiful, a beautiful little girl. And there were so many points where things could have been different for Darissa Bell. Aaron Anderson, who's become a very good friend of mine. I don't like standing next to him because I'm short and he's really tall. But he's a pastor, and a pastor of City Church. Came here from North Carolina, and very passionate in terms of that. And his understanding is, things just aren't accomplished on the pulpit. Aaron was not just their pastor for this family; he was their neighbor. And Aaron knew that something was not quite right. And I'm speaking for Aaron, but I've heard him say this in multiple open forums. So, and he kind of lives with the fact he knew that the mother's boyfriend, it just wasn't right. Darissa Bell's the mother's mother knew something was not quite right, but nobody did anything. For all the typical reasons that nobody did anything. So we had what I thought was this evening of angst. York Counts, which is one of the agencies that helped facilitate this program. And then what happened next? Almost nothing. So you had this wave of energy. And in response, KPOC, and I'm not good with the acronym for KPOC, but it's an organization within our York County Children and Youth that serves a function of kind of coalition building of prevention, looking at different prevention and service providers in the community, child abuse prevention. KPOC, it kind of got steered into KPOC's court, and a second forum was held. And I kind of take the blame for the forum because it did not achieve the results that I wanted. My blame is I was too peripheral to the process. I was the keynote speaker that evening and gave a talk on corporal punishment. Learned a lot about the literature on corporal punishment and the alternatives. The idea behind that second community forum was to develop tangible plans. What could we do next in York? But the structure of the program didn't allow that to happen. And I left that evening with a really sick feeling. Aaron was part of the panel, talked to him immediately afterwards, and he felt the same way, and saying, we got so many people to there, and we did nothing. Not only did we do nothing, we talked to them. I talked to them. Then the panel talked to them. But nobody talked back because we got 3 minutes at the end of the program. And so I felt really sick about it. The Front Porch Program is my efforts to revive that, and to still think about Darisabel, and not just Darisabel. One of the things I was reminded at the first community forum, because I was talking about Darisabel, as a mother stood up and said, "What about my baby? You know, my baby died too." And so you can't just say Darisabel. So I think it's really important that, and children and youth can have that central function, but within each community, who's going to be the champion? What's the structure that's going to sustain things? And we really wobbled in York. I'm hoping with this Front Porch Program that we can reestablish it. I've chatted a little bit with Bev. We need to chat more in terms of, is KPOC the best fit? Where should this prevention arm, where should it exist, and how should it work with children and youth?
Doctor?
Could you just describe the Front Porch Program? What exactly is it?
Anybody here, has anybody here done the training, Front Porch training, Teresa, have you? Okay. I'll know better next Friday, because I'm one of the participants in the Front Porch Program. And I'll send this, I didn't bring it with me, I'll send you the web information. But the Front Porch Program does have some literature validation based on surveys. It's a fairly rigorous 2-day program, 8 hours a day. So it's 16 hours that individuals are committing. The training is for 30 people at a time. The training targets community members. It could be anybody in the community, hopefully community leaders, looking at people within daycare settings, looking at the faith-based community, looking at schools, looking at neighborhood organizations, looking at making sure that there's a full range of representation of ethnic groups. And it's a program that focuses on lay recognition of some of the symptoms and signs that suggest child abuse. And not just recognition of how to safely what to do next, and how to safely. And there are other programs. There's one program from Pittsburgh, the One Kind Word program, that to me is kind of a very mini, and this may be conceptually wrong, Front Porch Program, because I think the Front Porch Program has more structures. After the Front Porch Program also has part of its program that addresses root causes, and so tries to provide some scaffolding for community members to not just hear about the things to do, but why, and some of the underlying root cause reasons. After the first program, all the attendees commit to a second program that's approximately, I think, 4 weeks later. The second program is the action planning program. So you're given homework after the first program saying, okay, we met, we talked about this, what are the things that fit the York community? There are about I think about 12 people in York have already taken the Front Porch Program, which surprised me. And again, it just kind of represented that we didn't kindle it. Great, we trained 12 people, but it didn't go anywhere. Is this? I thought it was one program out there. In terms of validation, what they've done to validate the model is they've done surveys 6, 12, 2 years later. In terms of, do you remember we talked about this stuff? Has it changed your behavior?
And the thrust, just so I'm sure I understand this, the thrust is really to encourage these people either to report child abuse, to at least identify it in the community, and encourage others to report.
Yeah. Yeah, I made, one of the things that I mentioned, is, people point fingers at children and youth, they point fingers at law enforcement. That's not the answer. That's part of the buttressing on both sides. The Front Porch Program is built on the concept is that children can only safely be raised within the context of the communities that they live in, and every neighborhood. And the Front Porch Program brings that training and philosophy to neighborhoods.
Ms. Mackers.
First off, Dr. Turkowitz, thank you so much for coming today. I've known Dr. Turkowitz for longer than we want to talk about, right? We were both on the Attorney General's Medical Legal Advisory Board many, many years ago, and we worked together in New York, and so it was great to see you here this morning.
If I didn't meet my wife and she didn't, who knows what could have happened.
Yeah. Yeah, we have. It's just nice to have had the opportunity to work with David all these years. It's been wonderful. His commitment to child abuse issues is beyond what I think so many people, the communities need to be. But that's, what you talked about with community is something that in my new role I keep thinking about over and over. In this task force, I don't know what we can do about that, but I think that's the crux of it. Because repeatedly communities tried to bring community members together. Today, everybody's talking about what's going on at Penn State, at State College, and the trial. And everybody cares and wants to do something and wants to be involved. How do you sustain that from time to time? And I don't know that you I'm not saying you have the answers, but I think that's something for all of us to really consider, because we've been here. We were here when there were other child deaths. We were here when there were other sensational cases. And then we kind of go about our business, and there's no home. And is Children and Youth the place, and I've been thinking about this in my new role, is Children and Youth the place for the home? I'm not sure it is. So I think we do need to really have these discussions within communities. So that's my first thing. I think you hit it right the nail on the head with those comments. My question really today is, could you talk a little bit more and flush out about the role that it's your number one, healthcare professionals with expertise in child abuse serving as closely integrated consultants. Philadelphia is doing that, as we know, and I love that concept. I think it makes a lot of sense. And but you have any thought, like take a third-class county, York?
Yeah, yeah.
Who we know you. They know you, but they work with you, but they don't. How would you see that happening?
I'm going to comment on your comment first, and then try to answer the question the best I can. I wasn't even sure if I was going to put all that prevention stuff in. I needed to talk to, just because the same thoughts. Is that really the purpose of this task force? And that's what I got to, because children and youth is. They're the investigative, and if we're starting, if we're already midpoint, and if we're talking about child-focused programs, it has to be married, it has to be coupled. We need to figure it out. Does it need to be in children and youth? I'm not sure, but it needs to be coordinated, and we need to support it. And again, how could it be sustained? Well, again, that's up to the legislature. You either buy into or don't buy into. You think about the anecdotal, personal tragedies, and if that doesn't move you, think about all the dollars. Now, the second, the question: how do I see this happening? I think what happens in Philadelphia is probably would be very different than what happens in York. I think what happens in York is going to be very different than what happens in the northern tier of Pennsylvania in terms of population sizes and variety of cases that you see. But I guess I don't have it that shaped in my head, but I see it as children and youth in York. Okay, my relationship. Been there a long time. Most of the caseworkers who've been there, all the supervisors, their director, know that they can call me at any time. Try to get back to them. I'm not always the most prompt in terms of reporting, but they know I'm available for PRN questioning about what to do about this case and that case. But I think we need to move from that PRN to more prospective review of all cases. One of the things that I've done in York is that I think has been a great program is the work that I'm doing with the sexual abuse nurse forensic examiners. A big problem that we had in York that exists throughout the state is very few physicians are either interested or qualified to do sexual abuse exams. Not only can they not do the exams, they hurt the children trying to get the information, and they can't interpret it when they see it anyway. So that's the state. An alternative model is taking these sexual abuse forensic nurse examiners, and I think the parallel is my relationship with them is we started with a situation in York that if you were sexually abused, you had to wait for me, my half a day a week, a couple of hours. It was a log jam. Now through a collaborative relationship, they're doing their evaluations. I still review most of the time it's 100%, but now I have a second level peer review. It's just that there's more upfront peer review collaboration, and I think we have to move away from the iceberg. Well, we can't really quite figure out this case, so we'll get Dr. Turkowitz involved. I think there's much more to learn. Just like those safe nurses needed a year or two of training and seeing, so do caseworkers. And caseworkers are not going to learn through their caseworker supervisors about some of the nuances of interpreting the very findings that trigger the investigation. So I just think the resources have to be, and I think that the resources have to be in terms of having a closer relationship and more perspective, ongoing involvement with cases, and peer review, whether it's a sampling or review of all the cases.
Good morning. It's nice to see you again. Just a couple comments. You described the community meeting you went to with the 800 to 1,000 attendees, and you left there with a horrible feeling. And the worst thing we can do is leave this task force at the end of November with that same feeling. So it's nice to see so many of you come that I know and highly regard. You brought a wonderful team with you today, and you ask who the champions are, and you all are those champions as you give so much to kids across the Commonwealth. So I personally thank you for that. But just to hone in on the last thing that Bev talked about, the barriers to your communication with children and youth. Yes, they know you, but can you identify is there one problem other than not having a routine face-to-face with them? What are the barriers to communicating with CYS from a physician's perspective?
Well, again, for me, I just don't think it's an expectation. I don't think it's built into their work culture that the most common, one of the more common situations, and Cindy, my fellow docs love this phrase, if you ain't cruising, you're not bruising. So talking about little people, so initially babies, you put them down, they don't go too far. Then they kind of get into the crawling phase. Then they become commando crawlers, like that. And when they're in the commando crawler stuff, that's when they can bump their head and so on. And a lot of what triggers, one of the areas of referrals is what do you do when you see a person with bruising? And I kind of cringe in terms of that so many of these cases, I just kind of hear a banter back and forth that comes to me, well, somebody else decided, well, that wasn't significant. Well, caseworkers shouldn't be the ones that are really sorting through the nuances of interpreting bruising. So I just don't think it's part of the work process and the workflow. It's a medical decision. In terms of interpreting physical, don't ask caseworkers. Now you can explicitly again train caseworkers in terms of this baseline, but I think right now it's really more the workflow and it's more the design of children and youth that basically that this decision making is in the domain of CYS, and then again through relationships in York and everywhere it's going to be different. The relationship is, well, they know they can contact me with busy cases. Now, part of the barriers is probably me, because sometimes I'm sure they'll get the message, oh, he's really busy. He's always doing this and that, and we don't want to overload them. And so I think we can prospectively develop relationships. Maybe there's some funding with these relationships, I don't know, but relationships that will allow me to say York Hospital. And one of the reasons I work at York Hospital is they let me do this stuff. Which I think is really important. But, to a degree, whether the relationship, again, is funding or whatever, but I think we just have to change work expectations and look at the systems and how they're coupled.
Am I correct to understand that the flow of information, when you're involved in the onset in an evaluation or examination, going into children and youth is pretty free-flowing,
yeah.
But there are a lot of cases that come into children and youth that may not rise to the physician getting involved, and we do what they call, it's a pet peeve of mine, minimal fact inquiry.
Yeah.
How do we get around that piece to make sure you get a medical eyes on this thing?
I now understand. Actually, that case that I mentioned, I was making it specifically vague, the recent case, exactly that's what happened. This is a little girl who presented with vaginal bleeding. She's 3 or 4 years old. And On examination, there were some findings that it was hard to tell. She was just kind of a squirmy, moving around child, and we spent a lot of time with her wiping away blood and trying to figure things out. And I knew and I was still left with a suspicion. I thought she had a small abrasion in the posterior of her shed, a tissue that, the fossa navicularis, the floor of the tissue in front of the hymen. And if you don't know what those terms are, that's okay, because most doctors don't know either. But it's just it's tissue. So I wasn't 100% sure, but I thought there was abrasion there. Bleeding, possible abrasion. I was with my safe nurse and said, call it in. I also told, that was the mom, I said, this is what's going to happen. I got a call from the head of my safe nurse team yesterday. They didn't do anything. They looked at it and didn't reach their threshold to go out and even talk to the mother. That was 3 or 4 days ago. I said, what the heck? They were waiting for my follow-up exam. I mean, my follow-up exam, which is going to be tomorrow, is probably going to be meaningless because what I saw is going to be gone. And I think that's an exact, what the heck went on there? Well, what went on there was a caseworker without the training in terms of interpreting medical findings. The kid's 3 years old. She is not going to make a statement. So I think the flaw was in that process. And I want a system in place that allows closed sampling, 100% peer review, that, again, and the size of this service depends on the county. In New York, maybe I can do this all. Maybe I can do this with the assistance of my safe nurse team members, of look at your cases as they're coming in and say, this needs your immediate attention. Not only did it not get immediate attention, it wasn't addressed.
Just briefly, you used they. I presume you mean CYS didn't do anything.
So far, as of about 72 hours later, they had decided they didn't go out, they didn't talk to the mother, it was sat on.
Do you think, trying to figure out solutions to those things that are very difficult, could requiring all those calls prior to doing minimal fact inquiry, requiring them to be numbered, do you think that would help us gather data to help do more objective review of those cases, peer review, that sort of thing? Do you think that would help?
If numbering means vigilance and the right attention by the right individual to each concern, yes, that's what I mean.
Thank you. First of all, good morning, Dr. Turkowitz. It's always a great pleasure to see you. I think David's one of the most wonderful pediatricians I know. I have a comment, and then I have a question. My comment is this. I do think, from where I sit, that part of the challenge of getting or having children and youth and doctors and healthcare professionals communicate effectively to protect children is in part a culture problem. Even sitting within the Department of Human Services, there are situations, and I've heard this throughout my career, where children and youth workers don't necessarily trust what physicians have to say. They think physicians may be biased in multiple ways. Maybe they're biased racially, maybe they're biased socioeconomically. And, I won't recount, but I can recount cases from this week where, workers can miss important, critical things because they don't communicate, even within agencies. So I think part of our challenge is not only kind of mandating cooperation, but trying to break down those cultural barriers. I'm hoping, Bev, that at some point when we're done with this very important work, we can, as really a state and a commonwealth, start to address some of the health care issues for children in the child welfare system. So I'm going to save that for a later date and ask this question. You talked a little bit, number 2, about kind of the problems with a 2-tiered CPS-GPS system. And I'm not sure, or I'm not exactly sure if I understood what your solution would be to that. Would it be to get rid of the GPS system, or would it be to more carefully measure and monitor and track what happens with GPS referrals? Any thoughts about that?
Yes, thank you. I don't think we need to get rid of. I think a 2-tiered system can work. I think a one-tiered system could work. I think it is important that Pennsylvania has comparative data to virtually every other state. And when you look at the reporting, which tells us that across the country, the majority of cases are neglect, and you look in Pennsylvania and you find, 3%, 5%, 7% are neglect, it's too much apples and oranges. And so I just think that in terms of just thinking about programs and replication models, that we ought to have a similar language to what's been adopted across the country. The second point is I think a two-tier system could work with the caveat, and you suggested this, Cindy, is you got to still be measuring outcomes. You have to still have expectations. You have to look at what you're doing. You have to measure it. You have to follow, and you have to follow the outcomes. There's another issue is the voluntary involuntary. And my concern again in Pennsylvania is by GPS, General Protective Services, I don't want it. And so the child is still left in involvement. And I think that gets back into the stringency of our definition in Pennsylvania. So I think both can work. I think a two-tier system needs accountability on both ends.
We've talked a lot about GPS, CPS, but we actually haven't talked about the fact that the GPS system services are all voluntary. So you can offer terribly neglectful parent services, and you're correct that if they don't want them, they just can refuse them. And I think that that's an issue that we might need to address as a panel. Thank you for bringing that up.
If I may, and there may be a few more people with questions, but I'd like to jump on this. I'm a prosecutor. I hear 3-year-old with symptoms or indications that suggest some foreign object, or I guess a penis, has been inserted partway into the vagina. Maybe. That's what you're saying, essentially, right? Why would a referral not be made to police who, in the best of all situations, and again it depends on resources and the skill of the individuals, may have the ability to get people to admit things that they're not inclined to admit?
Thank you, and I absolutely agree. What I told the mother in that case is that within 24 hours that she should expect that there would be a caseworker from Children and Youth and the police, which is part of our system, that report should trigger, serious physical harm, sexual abuse, 100% reporting to law enforcement. And that gets, I guess, in that minimal fact, it didn't even get through that door to get to law enforcement, and I didn't think of personally calling law enforcement because I said, okay, this is pretty darn clear cut to me. Blood, abnormal exam, call, I mean, the ball it didn't even get as far to be fumbled.
Well, we're at the stage now where we're sort of crafting recommendations, and we're going to huddle on them next month. But one of the things that I'm seeing, and we all have to kind of talk about this together, but an expansion of the idea of the CAC beyond just as a vehicle to interview children, and requiring that at least any suspected criminality be submitted, particularly that's coming from medical personnel. The referral initially is coming from medical personnel. Be submitted to a group of people, which certainly would include Children and Youth Services, but would include some sort of, ideally a doctor, but at least a nurse who's savvy and trained, and that as well as a police officer / prosecutor, or hopefully both, and that the balance of that consensus, that group can kind of work either way. No, this isn't criminal. We've seen this in other situations, wherever it may go, but capturing all of that expertise, and then tasking the medical component of that group. And one of the things we've heard both from Dr. Christian and other doctors, both on the panel and presenting, is that a doctor makes a referral and then just has no idea what happens, perhaps for months, requiring the medical component of that group to report per some kind of regulations that are developed, to the reporting and/or the treating physician if the reporting physician isn't, if it's an emergency room and then goes off to somewhere else. Is that something you would think would be beneficial?
Oh, and very much so. So yeah, I think in terms of that last point, if the report comes from the ER doc, now the ER doctor is not the longitudinal provider, but needs that reinforcement. I did all this. I changed. Yes, I'm protecting, but we're trained. We want follow-up. We do a test. We want the darn result back. But then I think the systems have to do the next thing in terms of making sure that the information gets back to the child's medical home. That not just the person who filed the report, but the child's primary care physician. Pediatrics and family practice has changed a lot. It's not a matter of giving antibiotics for otitis media. There's so much more emphasis now on how we maintain behavioral health and support wellness, and so the primary care doc needs this information. The Children's Advocacy Center model is a model that was created in Huntsville, Alabama. It fundamentally to address the fact that children who are sexually abused 90% have no physical findings. And so it's paramount that the history is correctly taken. I wasn't sure if you were suggesting this. I'm not sure that all abuse cases, I think you could take a CAC model and expand it to do all child abuse. Personally, I'm not really big on that because it's very different. Physical abuse is, from my processing point of view, is 180 degrees different than sexual abuse. In physical abuse, I'm seeing an injury, I'm seeing a broken bone, and now I got the physical finding, now I'm going backwards figuring out what caused that. In sexual abuse, I'm not seeing anything. And it's a much different process. And the people around the table supporting a CAC model are really different than the people that are often involved with the physical abuse evaluation. Where, again, it's not so much, history is important, but it's the processing of the physical findings. And the processing of physical findings often involve a whole range of specialists, not just child abuse. It involves your neurosurgeon, your orthopedic, people that aren't tied into your CAC.
Okay, but ultimately, I guess I'm looking at it from the standpoint of the system. At some point, the medical system, from an outsider's standpoint, comes up with a diagnosis. Yeah. Says, look at this. This is more likely than not, not accidental, needs to be looked at. And then the fact-finding process, from our standpoint, is, while the two are very different in a lot of ways, it's similar. And, of course, you've got the issue of CAC may not be relevant. A 3-year-old is very likely not, there's no way you can interview him, so that part of the CAC isn't relevant. But capturing the multidisciplinary aspect.
I think we need to be multidisciplinary. One of the things that Cindy mentioned, sorry, Cindy, because I'm old, so I'll lose.
You can speak for me too.
I'll lose this thought. Is Cindy mentioned that physicians can be biased. I mean, we are biased. A nice study that was done out of CHOP, one of the many, showed that if you were a black child versus a white child, you're presented with a long bone fracture of your leg. And if you balanced everything else, the black child was more likely to have an abuse report concern. We got a lot of work to do in terms of docs. Another thing to remember, and I don't know if this is going to come to task force. Sometimes I do, as you might expect, I'm subpoenaed quite a bit. And some people, when I'm on the stand, people say, "Well, you do child abuse all the time. You're biased." You think, and my answer is very succinct. Because I'm trained in the area of child abuse, like my colleagues, we're trained to recognize what is not abuse. One of the, if you have, and this is what's kind of tough about the field, is the outcome, the best outcome is not to put 100% abusers in jail. That sounds nice. Why am I saying that? If I try to put 100% abusers in jail, I'm going to throw the wrong people in jail. You can't be, you have to accept that there's, again, going to be some, and I guess what I'm trying to say is, it's, from a physician's point of view, you really want to be, yes, you need to be unbiased in terms of looking at all the factors. The other thing that Cindy mentioned is what happened in local children and youth in terms of, just these walls and barriers. And Yeah, I think that's our starting point, but I think the longer that you're there, integrated within your Department of City Health, the more, people are going to see you, see your colleagues, you're going to see them. It doesn't happen overnight, but it will change.
Yes, Doctor.
Yeah, so I just, I think we sometimes use kind of the term CAC almost interchangeably with multidisciplinary, right? Because it is a multidisciplinary model. So whether or not you investigate like physical abuse allegations at a CAC, which is really, often it's a physical place, I think the concept of mandating interdisciplinary and multidisciplinary investigations is really the critical process.
Yes.
I'm sorry we jumped over. Mr. Ibach, did you have questions?
I'd like to thank you very much for not only your attention, but to a very serious need. But I wanted to comment, it's been talked about a lot, and I actually underlined it before anybody said anything about it. I think the community aspect and cooperation is so important in the preventive piece. And you talked about, we certainly can't legislate and we can't point fingers. And that involvement, I think, is very important, so I commend you on that, and I think that's a very important piece. The other thing we keep hearing in testimony that's given to us, and I think we eventually will, when we have a time to discuss it among ourselves, the obstacles that prohibit the sharing of information. And my experience in those investigations proves, you prove exactly that point to me, which is my premise is always you can never get enough information on the table to discuss. No one, in my opinion, should be able to stop that process unless, of course, there's an emergency reason to stop it. And let's put all the information on, then we can make the best decision with the disciplines and the professionals involved. So appreciate the comments the chairman made, too, about the involvement of the police in this. And I hope that there is some, I'd like to know the end of the story. Thank you very much.
And last but certainly not least, Ms. Bernard.
Good morning. Thank you, Dr. Turkowitz. Most of the comments and questions that have already been posed to you I had down, so I'm not going to ask you a new question, but I would like to clone you and bring you to Blair County if that's possible. Really, we don't have a CAC or anything of that nature in about a 14 area county around us, and we come to Harrisburg or Pittsburgh to use those services. So I was intrigued with the idea of, and we've heard this before from other pediatricians and doctors, the idea of having a medical liaison work directly with Children in Youth Services. And I was envisioning, as was the chairman, that occurring under a child advocacy center model. And I guess the question is, how do we make that happen from a financial standpoint, and how do we attract the pediatricians to stay in Blair County? Our Children in Youth Services spent about $200,000 training 2 doctors who stayed about 6 months each and then moved on. So, there is a need for doctors in this area as well to have the sort of dedication that we're seeing from Dr. Christian and Dr. Berger and yourself to work on these matters. So, encourage your colleagues to stay in there and go to places where, we're in need of their services.
May I comment? Yeah, a second. Blair County is Blair County in terms of population. So if you get a person who does a child abuse fellowship, kind of likely they're going to go to Blair County because of just the volume and the number of cases. So your challenge is how do you sustain that model? How do you get the support? The preceptorship is we kind of call it a mini fellowship. This does not make that person a Rachel Berger or Cindy Christian and on another notch down to me or somebody else. But it gives them a greater foundation than most pediatricians are going to have. And I think that covers like 80-90% of your cases, because then as part of their network, they know us. They can call Cindy, they can call Rachel, they can call myself. So I think one is to look at supporting that preceptorship, because a lot of pediatricians are interested. They just don't know how to They don't know how to kind of jump in, so I think that's one possibility that's a relatively low cost, is to support this fellowship, because you don't need in Blair County somebody who's going to do 100 evaluations. You need them for their 5 or 10 or 15 evaluations that come up. Another thing that we're working on in Pennsylvania is the importance of peer review for experts. I think a terrible tragedy occurred in the Erie area in terms of the misidentification of what was called an expert by the court, that in terms of interpretation of physical findings, that I think really distorted prosecution. So I think as we develop and maybe as this task force looks at, I mean, it's a broader question probably, but I think there has to be ongoing peer review. So again, I guess specifically that preceptorship is one. Another is reach out to the Children's Hospital, and what defines your regional center depends on where your regional center may be 200 miles away, depending on where you are in Pennsylvania. But programs like the ones in Pittsburgh, or they have several doctors. I spent about 13-ish years at Geisinger Medical Center in the center of the state. They have cardiologists that go to Du Bois and Scranton and all over the place. They cover a wide geography. And I think we can look at models of developing relationships with the children's hospitals where you're child abuse specialist at the children's hospital. Because basically that's where most of them are going to exist, because that's where they have the volume of cases. I'm not the only exception, but I'm a little bit of an exception that I exist in the community. Because I do a lot of other things.
I appreciate those thoughts, and I think our goal in Blair County would be to be a regional resource for other counties that are in the same predicament that we find ourselves now. But we have a fairly large number of cases, surprisingly. So we could utilize someone ourselves, but we think we could pull from the other counties as a resource for them as well.
Yeah, it's just too bad that you got burned, and that's when we look at the primary care infrastructure in Pennsylvania, I kind of have the same. It's once you train, how do you retain? And it's difficult. It's a lot of resources.
I think one of the other things you didn't mention that we don't really, I don't know that as a Commonwealth we really take very good advantage of is telemedicine, where there are other states where you have that are rural, like Pennsylvania, that do offer some assistance by telemedicine, and I don't know how successfully, but that's something I don't know that we've embraced as a state.
Yeah, we haven't. Do you participate in the telemedicine thing that's out of Salt Lake City?
No.
Okay. So there is a national model out there that I learned about through the child abuse listserv. Block your name. Who's nice? Frazier, Lori Frazier. She's a child abuse expert out at the Children's Hospital in Salt Lake, where they basically provide this kind of telemedicine consultative type service. So the model is there, and I think Cindy, I think that's a good thought. I think that's an alternative model. I can kind of quickly come up with a half a dozen to a dozen of folks in Pennsylvania that I think we kind of that we could put together that could be part of a telemedicine network. Some of it kind of naturally falls into the folks that are already associated with the children's advocacy centers in the region to a large degree. So that's a good thought.
David, it's Rachel. Can I make a comment? Can everyone hear me?
Yes.
We actually have looked into the telemedicine issue. There's a couple of issues, and it's a really great idea. One of the issues is you have to pay the people who are doing it. But the even bigger issue in Pennsylvania is the issue of court. And so it's the couple of times that we've done it, we have come to regret it because we are then subpoenaed multiple times for prelims, for civil, for criminal. A single trial, I think most of us would agree to go to. It's the multiple prelims. We've driven 3 hours to be told the prelim was continued on a case we did by telemedicine. And so I think some of the issues related to what is the, quote, relationship with the patient and how do we deal with these issues of subpoenas. There's one thing to do it for child safety. There's another when it becomes a criminal case. And most of the civil cases you can do by phone. But that's been our biggest issue, and we stopped doing it, even though Children's is actually pursuing a lot of telemedicine because we haven't been able to figure out those issues.
Rachel, maybe that's why we haven't embraced it as a state. I don't know.
And actually, that's an excellent point, and we have had some contact with the Supreme Court in terms of that. That's one of the great things about this task force. It creates a setting. There's no excuse for that. There's just no excuse. A court can control its docket, and while the legislature can't mess ultimately with the Supreme Court, I think that there would be a willingness to tackle that issue.
It's really fundamentally unfair. All the technology we have, most if not all the MDJs now have video conferencing capabilities for setting bond in the evenings. There's no reason physicians can't come and extend some professional courtesy to them, let them testify at a preliminary hearing by video. It just doesn't make no sense.
There is no blessed reason if the doctor is going to be available at trial why they have to testify at all. But again, yeah, there you go. Doctor, and now we're hopelessly behind schedule, and not because of your expertise, not because of you, but let me just try something out. As I say, I've been working on my recommendations, and I suspect, given your breadth of experience, that you have testified at criminal trials. Have you ever testified at one where the injuries to the child were caused by excessive punishment?
Yes, many times.
Let me just try something out on you as a standard. The broadly understood, I've instructed I don't know how many juries on simple assault. And we'll leave the mental standpoint out for the moment, but from a physician standpoint, the impairment of physical condition or the causing of substantial pain. That's bodily injury in the Crimes Code. How would that be as a standard that you could get your arms around, looking at, assuming the child can't tell us anything, too young, looking at the physical injuries, struck me as a lot better than what we've got. But if you've testified in simple assault trials, that's more or less what you've needed to testify.
Yeah, and you know what? When I've testified again in those assault situations, I'm not sure if this is exactly the answer that you're looking for. I talk about the force that's required to cause that degree of bleeding beneath the tissues. One of the tests that I've started to get in these situations, because I think it sometimes helps juries, is a CPK test. It's a muscle enzyme. It's not found in your skin. It's found in your muscle. And when you see kids that are beaten, you often see these extraordinarily high CPKs that it takes running a marathon to beat your muscles up that much to get these CK levels. And it's my way of telling the jury this is not just a slapped child. This is, underneath the tissues. This is not an autopsy. But what this lab tells me is this child was struck hard enough that was able to disrupt and injure muscle tissue below. I think, again, I guess, in terms of looking at concrete examples, I think one can start talking about, the types of physical abuse that leave different types of bruising marks of what's abusive and not abusive. And I do understand that there's still going to be some grayness to that discussion.
I'm just smiling because, and I'm looking forward to the challenge of our working together. You have the happy situation of dealing with what's real, of something that's quantifiable. Lawyers have to deal with words, and it's the only way we can write laws unless we have one of those lists that's 1,000 individual symptoms long, but it is going to represent a challenge for us.
Well, I guess my comment is I think you guys are well chosen. When I looked at the composition of this task force, a little part of me was upset that I wasn't on the task force, but I think Bev heard me say this. I said, if I'm not on this task force, there are a couple of people that I want on it, and Cindy and Rachel were on my short list because I thought they could do a better job than I could.
Thank you. We'll make sure we define child abuse by CPK levels.
There you go. There you go. And there's been some, I think, concern. We're only halfway through our year. I would hope that we can fairly, in the short term, say 2 months, develop a fairly comprehensive set of recommendations. One of the things that occurs to me is to send them to everybody who testified. and see what reaction, input, let you folks ponder what we're at least churning with, and see if you have further thoughts. So we'll welcome an ongoing dialogue. Thank you very much. I think we've gotten everybody's. Oh, Judge Grimm?
Just very briefly, by way of comment rather than question, I'm pretty familiar with the Nurse-Family Partnership. It's been in my county about 7 or 8 years, and in addition, Dr. Olds has spoken at the JCJC conference. Its outcomes are phenomenal. It's the best prevention program that I know of in my 25 years on the bench. The comment is this, that whatever prevention program is implemented needs to have a dedicated funding stream so it's not subject to the vicissitudes of funding cutbacks. And secondly, as great as the program is, and as much as we know that not only are the outcomes great, but we spend a lot less dollars by having a program like this than we're going to spend later in treating kids and problems. But the problem is, how do we reach critical mass? You know, we have, I think, in Pennsylvania, maybe 15 or 20 separate nurse-family partnerships. We really ought to have a heck of a lot more. We're doing a lot, but we need to, I believe, realize that for effective prevention to occur, it needs to reach critical mass. And I'm just wondering your thoughts about that, Dr. Turkowitz.
I share your thoughts. I share your angst. I share your belief that this needs to reach a critical mass, and I applaud the efforts of citizens in our legislature to develop that will to protect our children. The Nurse-Family Partnership, as you know, is a program that targets a particularly at-risk population. So that's one of the ways it gets around the economics and sizing. There are other programs that are designed to support all families. So I don't have an answer. I think your comments were very eloquent. I agree. And the issue is how can the legislature focus long enough on this point to develop the will to put together the small amount, and at this time I realize that no amount of dollars can be really considered small, but by any analysis, the RAND Corporation, which has good data with the Nurse-Family Partnership, it just makes imminent sense to do this.
Thank you.
You're welcome.
Thank you, Doctor, very much. And now, Ms. McCracken, PSEA Treasurer, and who's been waiting patiently. Thank you. And if you'll introduce the gentleman you have with you. And
go ahead, John.
My name is Todd Park. I'm the Communications Manager for the Pennsylvania State Education Association.
Great. Welcome. Floor is yours.
Thank you. Good morning, Chairman Heckler and members and staff of the Task Force on Child Protection. My name is Dolores McCracken, and I am a paraprofessional in the Council Rock School District with nearly 2 decades of classroom experience. I am currently on leave from my position and serving as the treasurer for the Pennsylvania State Education Association. On behalf of PSEA's 187,000 members, thank you for providing me the opportunity to testify before the task force on the critically important issue of how the Commonwealth can better protect and ensure the safety of our children. PSEA believes educator training and awareness are crucial elements to identifying and responding to child abuse. PSEA's members recognize that as mandated reporters, they are a crucial part of keeping children safe, and we want to partner with you and the General Assembly in your efforts. The importance of the role of mandated reporters continues to be demonstrated by the data, which clearly shows that mandated reporters are the highest reporters of suspected child abuse. Of that, school employees comprise the highest number of total reports of suspected abuse. As you know, the system of mandated reporting of suspected child abuse was established by Child Protective Services law. Specifically, the CPSL requires mandated reporters to report instances when they have reasonable cause to suspect that children are the victims of abuse. These suspicions can arise in two contexts, and each is addressed differently under the law. From the perspective of school employees as mandated reporters, the first are those instances when they have reasonable cause to suspect that children are the victims of abuse outside of the school environment. The second are instances when they have reasonable cause to suspect that students are victims of abuse by fellow school employees. PSEA offers and has provided thousands of training sessions to our members regarding mandated reporting for school employees at no cost to school districts. However, we are not able to conduct these presentations unless we are invited to do so by the school districts. Speaking from personal experience, during my 20 years in my district, I have never been provided any training by the district regarding mandated reporting of child abuse. While I do not have any firm statistics, I suspect that there are thousands of school employees like me who weren't provided this most essential training for most, if not all, of the years they worked in a district. When PSEA does have the opportunity to provide this important training to our members, we encourage all school employees to ask themselves the following questions. Who is required to make a report? What types of abuse should be reported? When does one report? To whom does one report? The following is a brief summary of the main points covered in our trainings focused on helping members better understand their obligations under the current system of mandated reporting in Pennsylvania. CPSL requires mandated reporters to report suspected child abuse for any child falling under their care, supervision, guidance, or training. For school employees, this most likely expands their realm of responsibilities to situations outside of their scope of employment, such as when they are serving as coaches of community sports teams, scout leaders, etc. The law also requires all school employees to report fellow school employees they suspect of having abused a student. Child abuse is defined as any act of serious physical injury, serious mental injury, sexual abuse or exploitation, or serious physical neglect that is perpetrated on a child under 18 years of age. Student abuse is defined as serious bodily injury or sexual abuse or exploitation. School employees are required to report when on the basis of his or her medical, professional, or other training and experience have reasonable cause to suspect that a child has been the victim of abuse. School employees are not required to verify the abuse before making a report, and they receive qualified immunity from civil and criminal liability arising from such reports in the case of child abuse report. Additionally, school employees may not be discharged or discriminated against regarding wages, hours, or terms and conditions of employment because they made a child abuse report in good faith. The reasonable cause to suspect standard also applies to reporting in the case of student abuse. School employees must report any instance when they have reasonable cause to suspect that a fellow school employee has engaged in serious bodily injury, sexual abuse, or exploitation of a student. Those who willfully fail to report such suspicions of abuse are subject to criminal sanctions, dismissal from their employment with the district, and also loss of certificate if he or she is a certificated employee. School employees must notify the person in charge of the school, such as the superintendent or principal, or an agent of such person, as often outlined in the school district policy, that a child they regularly come into contact with as part of their employment is the suspected victim of abuse. If, however, a victim of child abuse is a child that a school employee does not regularly come into contact with through employment, but rather in a position such as a scout leader or coach of a community sports team, the employee should report directly to Childline and the County Children and Youth Agency. School employees who have reasonable cause to suspect a fellow school employee has committed serious bodily injury or sexual abuse or exploitation must make a report to a school administrator. The administrator must immediately inform local law enforcement officials of the report. If the local law enforcement officials have reasonable cause to suspect that there is evidence of student abuse, they are to notify the County Child Protective Service Agency, which will then begin its investigation. The county agency notifies DPW's statewide register of a pending complaint, and then the agency has 60 days to complete its investigation. If the report is unfounded, the agency will notify DPW so it can record it as such on the register. If, on the other hand, the agency has found substantial evidence that abuse has occurred, it will notify the register to record an indicated report. A founded report will be noted on the register that there has been a judicial adjudication that the school employee committed student abuse. Currently, school employees alleged to have committed abuse face investigation through 4 potential entities. 1, law enforcement officials who will determine if criminal charges should be filed. 2, by the Child Protective Service Agency, which will determine and record on the DPW register if abuse did occur. 3, by school officials who will conduct inquiries that could culminate in reprimand, suspension, demotion, or dismissal from current employment. And 4, by the Professional Standards and Practices Commission, which will ascertain whether the allegations are potential cause to withdraw the employee's professional license. Also, every applicant for school employment must submit to school administrators a clearance statement from the DPW statewide register, which will detail whether an applicant has an indicated or founded report. Administrators may not hire employees with founded reports. It is clear from this overview that school employees have an affirmative obligation to report suspected cases of child abuse and student abuse, and that there is a strong fabric of protection in place for children, but we can and we should do more. As I noted at the outset of my testimony, there are a significant number of school employees who have not received adequate training outlining their obligations as a mandatory reporter. Ensuring all school employees receive quality training on how to identify signs and risk factors of abuse and additional guidance on when and how to report suspected abuse is critically important. While PSEA has delivered quality training programs for thousands of our members on the topic, we also recognize the limitations of not having mandated reported training as a requirement for all school employees. For this reason, PSEA supports Senate Bill 449, sponsored by Senator Pat Vance and currently pending in the House, which would establish a training program focused on the recognition and reporting of child abuse. The bill requires at least 3 continuing education credits in this area every 5 years. Now, moving from the school employee as the mandated reporter to incidents where the school employee is the suspect or perpetrator, PSEA has worked diligently with stakeholders on legislation pending in the Senate, Senate Bill 1381, sponsored by Senator Williams, to improve the bill from its original form so that it strengthens safeguards for children, particularly around sexual abuse and grooming behaviors, while still protecting the due process rights of the adult. The issue of protecting children while also ensuring due process rights for employees is a difficult road to navigate, but it is an important one. In an effort to strike this difficult and important balance, we support the current law, which holds that a founded report should be a conclusive bar to prospective employment. We also appreciate that a founded report might, without further proof as to underlying facts, be sufficient in and of itself to revoke a teaching certificate. Finally, we believe an indicated report could also impact continued employment or certification so long as due process is afforded. In addition, concerns have also been raised by various stakeholders about the differences between the current statutory definitions of child abuse that occurs outside of the school setting and student abuse by a school employee. PSEA recognizes that both definitions may need to be revised in order to fully protect children and provide clarity for reporters. While we don't have specific language to offer to the task force today for the definitions, we do want to be part of the dialogue if and when those definitions are updated. In closing, teachers, school nurses, school counselors, school psychologists, home and school visitors, paraprofessionals, and all school employees share the same immediate concern when they suspect a child is being abused, the safety of the child. We stand ready to work with the task force to improve safety for our children in the Commonwealth. Thank you for taking the lead on this critical issue, and thank you for providing us the opportunity to discuss it with you.
Thank you. That's the testimony, okay? Ms. Bernard, the last shall be first. Do you have questions?
Thank you. Thank you
Comments?
very much for coming and being patient with us this morning. I have a couple of questions. The PSEA, does that include any higher education, or is it strictly elementary to high school?
The PSEA also does represent some of our higher education professors.
Okay. And is that something they can elect to join?
Yes.
Okay. As far as the paraprofessionals, I know that our school district has in-service days for the teachers where they're given education. The students have the day off, but the teachers have to go to school that day. Are paraprofessionals included in those educational trainings that are offered through districts, or?
That's a good question, and one that's very timely, because Chapter 14 regulations now require that paraprofessionals receive 20 hours of professional development annually. So because of that Chapter 14 requirement, many school districts have now begun to include their paraprofessionals in-service programs that they have for their teaching staff.
Okay. And so I'm assuming then school nurses, school counselors, ancillary members of the teaching staff would also be participating in these in-service days?
Yes.
Okay. And I think we've heard resoundingly clear that training is always important, and you're saying that even though your association offers that, the districts have to ask for your association to come and be the presenters for mandated reporting.
Correct. PSEA cannot go to a school district and require that they allow us to come into their district and provide this training. We have to be invited to do so.
Okay. But there are other organizations that maybe provide mandated reporter training that the school district could be utilizing, correct?
There are other organizations that provide training, and there are some school districts that have people on staff that they've had trained that can also train the existing staff.
Okay. Now, and you pointed this out, and I thank you for doing so, one of the things that we have been so concerned about is the discrepancy between children that are being presented as abused by someone outside the school and children that are presenting to a teacher or a member of a school district being abused by someone inside the school. And it is something that I think the task force sees as a major issue. You don't have any language to present to us today, but do you envision having something in the near future that we could utilize during our deliberations or work sessions?
We recognize that the bar is higher when it comes to abuse by school employees, and we would welcome that opportunity to help frame some language.
I think one of the goals for us to accomplish is to simplify things for people, and as you've heard, even from Dr. Turkowitz today, is keeping it simple helps people remember it a lot easier, and you don't have these series of steps that people have to analyze themselves when they're trying to decide what should they do or what are they required to do under the law. And clearly, in the Penn State situation, there was some of that going on, people not understanding exactly what their obligations were or understanding them and not following through with their obligations. So I think that would be very helpful if you could give us a time frame on some concrete suggestions that you have. We all talk about, I think we all have good intentions, but we all talk about change. Yes, changes need to be made, but we would like to know exactly what you are suggesting as proposals for us to consider.
We would welcome that opportunity, and we will get those definitions to you. Great. So that we can work together. PSEA, I believe I can speak for PSEA since I am their state treasurer, but as a school employee, we do not want school employees working in our public schools that are abusing our students. And PSEA will not represent a member in a criminal case.
Well, I think I'm glad that you said that, but I think it goes without saying that your group would not want to be exposing children to people who are predators or people who are physically abusive to the children. So thank you, though, for making that a point to say that in public. I don't have anything further at this point. Thank you.
I don't forget, Ms. Romberg, Mr. Ipoc?
Yes, thank you very much. Just a little follow-up on the last question. So certainly, when a staff member in your school has been accused, you say one of the important ingredients is due process. That's what's fair for the school, the child, and the employee. Is there any legislation that you cited here? I made some notes, but any that addresses that particular issue, or any recommendations or any ideas that you may have?
I'm not sure I understand the question.
Is there an internal, the due process issues that face the accused?
Yes.
Or most of those addressed through the criminal? I'm coming from a completely different framework, but they would be handled through the criminal justice system,
Yes.
correct? Okay, well, that explains it.
Unless, of course, understand that we do have members that may have an indicated report, and the member, in consultation with the PSEA attorney, is not willing to accept that indicated report because they believe so strongly in their innocence. And then, yes, PSEA would represent that member through the grievance arbitration process.
Okay, thank you.
Mr. Koulakis.
Thank you. Just to follow up on that last point, there is an appeal process, just so the record's clear. There is an appeal process for an indicated fine of abuse to the Department of Public Welfare as an administrative law process. So there are due process checks and balances in both the situation where a case is founded, usually through a criminal conviction, or a CYS indication. And do your counsel provide legal representation through the administrative law piece up through DPW?
Yes.
Just curious, how many school districts have not invited you to come do their training? I mean, do you know how many?
Todd, do you know how many trainings we've actually conducted?
I mean, we literally have done thousands of trainings, probably since the mid-'90s. You know, the law was amended in 1995 or 96, I think, to include student abuse. And at that point in time, there was quite a few trainings that occurred because the law was new. And then when the law became, relatively routine and there weren't any big public events, the request really went down for the training. So, I mean, it's not a situation where I think we go in and say, hey, we want to do this training, the school district refuses. It's just that it's not something that's on their radar. In other words, they're looking at something else that they want to provide the training for, an in-service day or Act 80 day.
I've done a great deal of work in this arena, and there have been quite a few people come before this task force and ask us why there's a set-aside for student abuse in the CPSL. Is PSEA in a position, or have they discussed their position on willingness to agree that we should simply dumb it down and make it just a CPSL without a set-aside for school abuse?
I think there also needs to be recognition that when you're a school employee, you do put yourself in a position where you may at some time be looking at, have I abused a child because I've just protected another child? Have I used force to protect myself? And I believe that that's where the fine line is, and maybe that's why we don't report to children and youth. Maybe that's why we do go directly to law enforcement, because law enforcement has the knowledge to investigate and to know whether or not it rises to the level of physical abuse.
Fair enough. But is PSEA willing to consider the value for the big picture, the big system, of eliminating that set-aside? If we tweak the CPSL generally to maybe address that concern. And maybe you can answer this in the future from a board meeting perspective. I'd like to hear what their position is. And frankly, I'm of the mindset that it is a good thing, and I see a lot of the professionals saying, yeah, it's a good thing if we consider eliminating the set-aside for school abuse to make it simple and dumb it down. So I'd like you to come back with an answer, if they're willing to come forward with a formal answer on that issue, because I'm going to push to take a position on it, and we want to be candid and hear from the stakeholders, and certainly you are a big stakeholder. So if you could do that,
I think if you look at the definitions as a whole, there are certain pieces of the definition of child abuse that in a school setting, I'm not sure that neglect is defined properly in a school setting for a school employee. As a school employee, I can look at a child who's come to school in the dead of winter wearing shorts and doesn't have a coat, and that may seem neglectful to me.
But we're talking about reporting suspected child abuse, not neglect. And I don't want to get into debate whether teachers should intervene on that. Clearly, may be considered neglect or not. But just reporting child abuse, which is physical, emotional, or sexual abuse. I'm really
I'm not going to
struggling.
speak for PSA. I'm
Okay.
going to speak for myself. And as a school employee, as I said, having worked in a classroom for almost 20 years, I believe that it's my moral obligation to report.
And I get that from your testimony, certainly. And then lastly, there's been a lot of discussion about what do we do with mandated reporters that fail to report. Can you address that? And one of the things I've thought about is many mandated reporters have some immunity shrouds, like school employees do or school districts do. Should we consider tearing down that barrier of immunity for when a mandated reporter fails to report?
I'll speak to the issue of school employees. If a school employee fails to report another school employee for suspected abuse, that school employee who failed to report can be disciplined, discharged, can also suffer criminal prosecution. Those failures to reports will also be turned over to law enforcement.
I want to focus in on the immunity issue from a civil perspective, because sometimes money talks, and if we make it easier for the child that's been victimized to have a big say in the civil arena and not have to fight an immunity defense, that might make mandated reporters even more encouraged to report.
Agree.
So I'd like PSEA to also look at that issue and give us a position on that as well.
We'll do that. Thank you.
Ms. McCracken, thank you very much. As, just the pediatrician, I have to be honest that for years and years I have agreed with Dr. Turkowitz. I have no idea why the schools were set aside or kind of carved out and given special definitions and special mechanisms, and child abuse is child abuse, and we rely on our teachers who see children every single day to really be the sentinels for communities to recognize abuse. So I come with a slant towards making these laws simple, making them the same for everybody, and not saying, okay, well, this one little group here has their own little laws, and they're different from everybody else's laws. So I would also appreciate kind of what recommendations specifically you all would have. But I have that's my comment, and now I have a question. My question is, part of, I think, the confusion or the difficulty that the community, meaning everyone in Pennsylvania, that was highlighted in part in the Sandusky problem, is that there seems to be in schools a mechanism by which somebody who has a suspicion reports to somebody else who may report to somebody else who's then responsible for reporting or making a report. And what happens on occasion is somebody may be suspicious and their administrator may not be suspicious and try to, quell that. Or somehow things get lost in translation and nobody makes a report ultimately. And so I'm curious about kind of what you understand about how reports should be made and whether you have some thoughts about changes in how reports of abuse that are just raised at school, I don't care whether it's by a parent or a teacher, how those reports get made?
If I were to go to my building principal and tell my building principal that I suspected that another school employee was abusing a student, I would expect that my building principal would do what he is required by law to do. For myself, I would want the acknowledgement that that had been done, but I don't know that he or she is required to do that.
Do you think, as the person who suspects the abuse, you should also have a requirement to make a report?
Unless we're going to train every school employee, then I would have to say no, because our school employees, for the most part, even without training, know that if they suspect abuse, they should go to their school administrator. They don't know that they should call children and youth. They don't know that they should call Childline. They go to their administrator.
Should there be some mandate or requirement or something that where that person who has a suspicion is ensured that a report has been made? Do you know what I'm saying?
For myself, I would want to know that that actually happened. I think one of the things we also need to recognize is that when we talk about school employees, we are not just talking about people who work in classrooms or people who are school district employees. We're talking about subcontractors who are working in a kitchen who may overhear a conversation. Mm-hmm. We're talking about school bus drivers who may have a suspicion based on what they've witnessed or things that they've heard. And if we're going to require that there be training, we need to also include those groups of people who have contact with students.
I'm almost thinking about a system. So if I were working in a school cafeteria and I heard some child tell another one about, they've been sexually abused, and I went to my school administrator, I don't know that it would be necessarily bad that the administrator and me, the cafeteria worker, together made a report. Just some mechanism by which we ensure that concerns are actually reported, because I think that that's part of the problem that we are seeing in the newspaper. Concerns got reported to higher-ups, and then nothing happened. So if you have a concern as someone who's working in a school, and you tell your administrator about that concern, but you don't have any idea if it really gets reported or not. I mean, just kind of seems to me it leaves you hanging out there, not really knowing or necessarily trusting that your administrator is going to do the right thing.
As a school employee, if I did go to my administrator and the law required that we both jointly submit a report, and my administrator said to me, I've done some investigation and I don't believe that this is a founded report. As the employee, I now need protection, because if I'm required to make that report, even though my administrator has told me not to make that report, I need to know that I'm protected.
Okay, that's fine. Thank you. I appreciate your answers.
Judge Grimm, do you have any questions?
Yes, one question. I know that you've done a lot of training regarding this issue. I guess my question is there any kind of a boilerplate or blueprint language that you provide to your members and or schools with respect to developing policies and reporting procedures on a school-by-school basis?
We're not really asked a lot of times what our input's going to be on school district policy. So that's really a matter up to the individual school districts.
So there's no statewide guidance?
Our statewide guidance is for our members. We are in discussions with both the School Boards Association and PASA, the Administrators Association, to work something out. We do have a rather extensive PowerPoint that we've developed, and we're asking them to buy into that as well, so that we will be coordinating our efforts, but that has not yet been finalized.
All right, thank you.
And Doctor, any questions?
Nope, I'm good, thank you.
All right, Ms. Macker.
Thank you. Just briefly, you talked about in your testimony, first off, thank you so much for being here. But you talked about in your testimony about the 4 investigations that could occur. And do you think that schools are, of course, there's a law enforcement investigation, there's the Child Welfare Agency investigation. Do schools have enough information about what an investigation should look like that they're doing? Do they talk to the child? Do they not? Does it vary? Do they meet with the alleged offender?
I'll speak from personal experience. In my school district, we did have a report of suspected student abuse. And not only did the school district immediately turn that over to law enforcement, they also knew that they needed to do their own investigation because they needed to know whether or not there were if we had employees who were aware and who failed to report. And what they did was they went and hired an outside team to come into the school district and conduct that investigation for them, people with the experience to do it.
And see, one of the things that you're not aware of because you haven't had the opportunity to hear all the testimony unless you listen to it online, we've talked a lot about how critical it is that we work as a multidisciplinary team, investigative team, to have one child interviewer, as few as possible, so that we don't traumatize the child more and that we get one consistent statement and we use the CAC. So I'm just wondering if, when I saw that in there, I'm wondering if we're pointing out another issue, which is we have more entities who are interviewing children, interviewing offenders that may not be connected with the law enforcement investigation or the child welfare investigation.
My personal experience in my district with that particular case is the team of investigators did not come in to investigate the actual abuse allegation. They did not deal with students. They did not deal with the abused. They dealt with other staff so that they could determine whether or not there had been any adult who knew of the abuse and failed to report it.
But is there guidance to schools so that they all do it the same? Because I'm aware of several situations that were done differently than that. So is there guidance that is put out for schools?
I suspect there's 500 different approaches.
That's what I was worried about.
500 school entities. Some districts that are larger are more sophisticated, have their own human resources manager. Other districts, the principal or the superintendent effectively wear like 12, 13 different hats.
Sure.
It also depends on who the solicitors are for the school districts. Some solicitors represent a wide group of districts. They are probably tend to be more sophisticated in how they approach it. And others might not deal with it as much. But I think generally the school districts do follow the lead of law enforcement, which I guess brings me to a point. You talked about the 2 different reporting systems, and is it confusing? I think that having the educational employees report suspected student abuse to ultimately law enforcement through the principal actually is effective, because I think the law enforcement generally tends to get involved a lot quicker, and when you do have somebody who has a serious allegation against them, it gets them out of the school building much quicker.
Thank you.
I can tell you in my school district, when that allegation did come forward within 1 week, 2 people had been terminated and turned in their certificates, and another 2 individuals were terminated for failure to report.
If I may, one of the perceptions, at least that I have, as to how this system evolved was the simple proposition that we don't want multiple people making multiple reports of the same incident, And it had occurred to me, and I was interested to hear you say, that if we make everybody a mandated reporter, but make it a complete defense to criminal liability and affirmatively say you've discharged your duties, if you do report it to somebody else who gives you written confirmation that they have reported it to whoever the required reporting entity is, that's something that would you folks, I'm not asking you to take positions today, but that makes sense to you.
Yes, it does.
Okay. One of the issues that we end up having to deal with, and it's going to be interesting to see how we can come to grips with it, there are different kinds of things that happen to children just logically based on their age. A kid who's over 10 or 12, in most cases, is going to be able to speak up about physical abuse. Sexual abuse, there are other issues that come into play. Do you folks keep any statistics? I mean, my guess is that there are relatively few claims of physical abuse against teachers.
I believe no, you're absolutely right. I believe last year there were 8 reported cases of sexual abuse. There were no cases of physical abuse.
Yeah, that and that's one of the things that's tricky. You mentioned the consideration of when one of your members is liable to be in physical conflict with a child. It's more likely to be defending another child or defending themselves, and I can picture that particularly with an older child. I don't know, maybe I'm just talking out loud. I'm not sure. I would assume that apart from self-defense or defense of another, these days, whatever may have been the case when this law was initially passed, these days your folks aren't trained. There's no thought you're going to have physical contact with kids in any kind of a disciplinary way. Unlike, I wanted to say warden. I didn't. My principal, Mr. Kutz, after whom we named an elementary school, he had his paddle, but those were better times, I think, but different times at any rate. Any thoughts on that?
I think as time has gone on and more of our staff, our school employees are aware of situations where it is okay to touch a child because you are protecting yourself, you are protecting another student, you are protecting that child from himself.
Sure.
But I think Todd would agree, Todd also happens to be an attorney, that we also tell our members, you do not touch children. You do not touch children.
I'm just one of the things that I wonder about all these fancy definitions. I'm wondering if they haven't sort of outgrown whatever usefulness they may have had, their relevance to the real world today. But at any rate, thank you.
Just to follow up on your training, do you have components in the training that touch on Title IX and the Clery Act? If you're familiar with those things.
Not in a specific training, no.
All right. Is there any? Ms. Bernard? Yep.
Sorry. I've had a few cases involving some special needs children where physical intervention was necessary with those children. And there was a concern raised by the parent about the extent to which there was physical touching between the teacher and the student. Does the association have a position when it comes to those children where it seems that that particular field is actually advocating that certain children require that physical contact in order to calm them down or in order to address other situations? Do you have any position on that today, or?
That would actually be addressed individually for each student through their IEP.
What happens when 2 students get in a fight in your school, 2 adults, adolescents?
What happens? Do you mean as far as other adult interaction?
Yes.
Well, what we hope for is that there will be an adult who will be able to break up the fight. I will tell you that several staff members in my school district, myself included, have gone through training as to how you break up a fight without putting yourself in harm, without putting other students in harm. The discipline then goes to the appropriate individual, and in my district, if two children are fighting, it doesn't really matter who threw the first punch. They're both going to be suspended. But there is training.
So there's physical involvement from a
Yes.
teacher? Okay.
Yes.
We're having a sidebar. Anybody else with any questions for the folks from PSEA? Thank you very much for participating. All right, I believe that concludes the folks we have scheduled for this morning, and I believe that that our first speaker for the afternoon indicated that he could be available a bit earlier. So I assume we don't have this kind of a link up for lunchtime with our two remote members. So we're going to shoot to try and get going. We'll give ourselves an hour, let's say at 20 of 1, which is different from the agenda. So we'll get started a little bit sooner with Mr. Jackman. And the one matter I think we can discuss, it's not really public business at this point, but there's been a lot of emailing back and forth about the scheduling of a speaker for July, and we've made an effort to get him in, but I think all the various members who expressed concern about having that working period of time not any more degraded than it has been already are right. And why don't we figure, it occurs to me that it may make more sense to have him later on after we've done some of the things we want to do anyway, so that we'll go ahead and schedule, and again, I'm having a senior moment, schedule Mr. Veith for later on in the summer or early fall. So with that, we will adjourn and try and get started in an hour's time. Thank you.